methylmalonic acid level, and if it's elevated, the patient's B12 deficient and you should treat them. Well, what's the problem with that? Well, we don't have any studies saying that if you treat patients with elevated methylmalonic acid levels, you actually get improvement in their any sort of symptoms. So there have been a couple of studies in elderly patients who've had low normal B12 levels, elevated methylmalonic acid levels, and they treat them with vitamin B12, and they found absolutely no improvement in cognitive function or in abilities to do ADLs or anything like that. So the jury is still out on this one. You're going to see probably a lot of changes in the future about overdiagnosing B12 and treatment of B12 deficiency. Pernicious anemia. Now, remember that this is an autoimmune disorder, and it's associated with thyroid disease, Addison's disease, vitiligo, and gastric cancer. The intrinsic factor antibody is very specific but not sensitive. So if I have a patient who has vitamin B12 deficiency and I have a positive intrinsic factor antibody, I'm going to stop and say this is pernicious anemia. On the flip side, if I have a patient who has an antiparietal antibody, it's sensitive, but it's not real specific. So I can't stop there and say, absolutely, this patient has pernicious anemia. Elevated gastrin levels are also very sensitive, but not specific. So if you're left in a situation where your intrinsic factor antibody is negative and you want to get more evidence that this may be pernicious anemia, you can do the Schilling test. And you know, if you're like me, I used to cringe when someone would ask me a question about, well, what's the Schilling test? So we'll briefly go over this. So how is this done? Stage 1 of the Schilling test is that you give the patient radio-labeled oral vitamin B12 and you inject them with non-labeled B12. So the injected B12 saturates all the sites in the body so that all of the radioactive oral B12 that can be absorbed is absorbed and actually is just supposed to go in the urine because all your sites are saturated. So you measure a 24-hour urine, and if there's less than 7 to 9% excretion in the urine, then you have an abnormal Schilling test. And then what do? You go on to the next level, which is stage 2, where you give the radioactive oral B12, you give the IM shot of B12 to saturate the sites again, but then you do a intrinsic factor chaser on that. So you're giving them intrinsic factor to say, hey, is the problem an intrinsic factor deficiency as you see in pernicious anemia, or you can also see in gastrectomy and things. And so if they correct, meaning they excrete a normal amount of vitamin B, radioactive B12, then that's considered consistent with an intrinsic factor deficiency, and in a lot of cases, pernicious anemia is the most common if they don't have gastrectomy or something like that. Remember that intrinsic factor is secreted by parietal cells in the stomach, and it helps the absorption of B12 in the terminal ileum. Now, if stage 2 is also abnormal, then you need to think about other diseases like bacterial overgrowth and celiac sprue. And so there is a stage 3 to the test where you can put people on a gluten-free diet for a couple of weeks and then do the test, or you can give patients antibiotics and then do the test and see if it corrects them. Folate deficiency. Now, this is usually caused by dietary deficiency or impaired absorption like celiac sprue or short gut. Drugs can also interfere with folate metabolism. Anticonvulsants like Dilan, sulfa, alcohol is probably the most common cause. Remember to check the red blood cell folate instead of the serum folate. The serum folate is more likely to represent the meal you just had rather than tissue levels of folate. What I want to give you is an approach to hemolytic anemia because I think it's probably the most challenging because we don't see a whole lot of cases of it. There's a 3-step process that I like to start with when approaching hemolytic anemia. Step 1 is confirming that hemolysis is present, and the things that you see are the elevated reticulocyte count or reticulocyte index, an elevated LDH, an elevated indirect bilirubin, and a lower absent haptoglobin. Now remember, haptoglobin is a protein that's synthesized in the liver, and it binds free hemoglobin. And so if you have hemolysis, there's a ton of free hemoglobin around, and the haptoglobin binds it up real quick, and then it takes it over to the reticuloendothelial system to get destroyed. The problem is that the liver can't keep up with the degree of the free hemoglobin, and so the haptoglobin levels go very low. And so that's another marker of hemolytic anemia. The second thing is you want to look at the smear, and you specifically in the beginning want to look for spherocytes on the peripheral smear. If there are a good number of spherocytes on the smear, it suggests either immune hemolytic anemia or hereditary spherocytosis. The third step is you do the Coombs test or the direct antiglobulin test. If it's positive, it's very, very sensitive for immune hemolytic anemia. There are a very, very small percentage of patients with hemolytic anemia that present with a Coombs negative immune hemolytic anemia. So let's talk about the Coombs test or the direct antiglobulin test. So this is done, and it's done to detect antibodies that coat the patient's red blood cells. So what you do is you take the patient's red cells and you mix in this anti-human globulin, which basically has anti-IgG and anti-C3 on it. And so you just throw that in there, you shake it up, and if agglutination occurs, the test is positive, and you have an immune hemolytic anemia. And what they then do is they tell you, well, did it react to IgG, or did it react to C3, or did it react to both? And that determines what kind of anemia you're dealing with, and we'll get to that in a minute. So this is contrasted with the indirect Coombs test that is used to detect antibodies in the patient's serum. So you take the patient's serum, you mix in normal red blood cells, and then you add this Coombs reagent or the anti-human globulin, and you see if anti-IgG and C3 act, and then you go to try to identify what the antigen is. The indirect Coombs is really only useful for transfusion reactions and alloimmunization kind of problems, again, when maternal fetal problems as well. So immune hemolytic anemia, there's a few types. There's autoimmune hemolytic anemia, there's drug-induced hemolytic anemia, there's transfusion-related hemolytic anemia, and they're distinguished by the history and identification of the specific antibody coating the red blood cell or the results of your direct antiglobulin or Coombs test. Let's talk about the non-immune hemolytic anemias. Again, you're not going to really see a lot of spherocytes on these patients, and the Coombs test will be negative. So there are two basic categories. There's the acquired and the inherited. Let's talk about G6PD deficiency. Hemolysis occurs during oxidant stress by a drug toxin or infection. And primarily the drugs involved are permaquin, sulfa, dapsone, nitrofurantoin. You can see bite cells on the smear, but it's not specific for the disease. The thing to keep in mind is that the A- variant is what you see in African Americans, is associated with self-limited hemolytic flares. And the thing to remember is that only the older red blood cells are affected. So in a patient who is actively hemolyzing and you have a lot of reticulocytosis, there's actually a normal level of G6PD, and so their G6PD screen is actually negative. But if you were to test them after their hemolytic flare is over with, their G6PD level will actually be low. And so you retest them in a few weeks and you'll make the diagnosis. Now the Mediterranean variant is a lot more severe. The G6PD screen is always abnormal since all red blood cells are affected. Some of you may remember, probably in med school, you were told about favism and people who ate these fava beans getting massive hemolytic crisis. And a lot of them are of Mediterranean variant and have this other variant of G6PD deficiency. Now there's a number of other variants. These are the two major ones. Microangiopathic hemolytic anemia, and I'm just going to touch on this. Things to remember, schistocytes are seen on the peripheral smear. Think about TTP, and the only thing I'm going to say about this, remember the 5 things, although you don't need all 5. Fever, anemia, thrombocytopenia, renal disease, and neurologic abnormalities, hemolytic uremic syndrome. Think DIC if the coagulation times are abnormal. Also think about prosthetic valves causing a microangiopathic hemolytic anemia. Sickle cell disorders. You have SS, SC, and sickle beta thal, and probably the degree of severity is in descending order, so SS is more severe than SC, and which is more severe than sickle beta thal. Again, that's a generalization, and there are variations in all of that. And it's characterized by vaso-occlusion and chronic hemolysis. It can affect virtually every organ system. Sickle trait, again, is not associated with clinical abnormalities. Death arises from infection. Think about streptococcus, think about H. influenza, and think about salmonella, especially with osteomyelitis. Death also comes from stroke and acute chest syndrome. To manage pain, you use nonsteroidals, narcotics, and fluids. We really have not progressed much in the way of treatment of sickle cell disease over the past many, many years. There are a number of experimental therapies, including nitrous oxide,